talk for today is a very young and talented surgeon from Mumbai. Not so young anymore, but very talented nonetheless. And he is a great corneal surgeon. So remember that all of us as cataract surgeons, sometime or the other, we are going to have endothelial difficulties and uh, Fuchs dystrophy and corneal edema post-op. And how should we handle this? How do we do DSEK ourselves? So DSEK for the cataract surgeon is the topic I gave him. And I also do DSEK myself, which I also learned from Rajesh Fogla and by watching Jatin. So I thought Jatin can share some very important and helpful tips how an average cataract surgeon like me can do a DSEK surgery himself without having to send the patient to LV Prasad or to the corneal person down the road.
Thanks, Cyrus. Thanks for calling me not so young. And you're not an average cataract surgeon, an excellent cataract surgeon. So just the layout be, why should we really learn DSEK as a cataract surgeon? What are the instruments that we would need to have? Simple steps in terms of tissue preparation, insertion of graft, and managing the graft in the eye, and post-operative regimen. So on table, a lot of times we see patients may have a large Descemet detachment, or sometimes the Descemet is just eaten by a phacoprobe inadvertently. Patients may have Fuchs dystrophy, or your own patients may be having a PBK. And it's not always possible to call a friend to do the procedure when it's quite simple to perform. Well, instruments are nothing very special. All you need is your cataract set. Tissue preparation does require an artificial anterior chamber, which is easily available with Epsilon. You need a reverse Sinskey hook, your cohesive viscoelastic, a sheet glide or a Busen glide. These are all simple instruments which most of us usually have, or we can prepare them using our own cataract set. So the surgical technique is quite simple. The first step is to prepare your donor tissue. Second is to decide how would you do your surgery in terms of site of incision, your anterior chamber maintenance, Descemet stripping, donor insertion, air management, and securing the wounds. So tissue preparation starts with selecting a proper tissue. Usually any donor which we will get from the eye bank, having a donor cell count of more than 2200 cells is good enough. And scleral rim should be adequate in terms of the shortest diameter should be around more than 15 millimeter size. Well, today we are really lucky that eye banks do prepare us DSEK tissues and provide us. However, in case we don't have an access to a pre-cut tissue, we can still dissect them manually. And even that does not require any special instrumentation. So all we can do is just mount it on an artificial anterior chamber, pressurize it properly, make a 400 micron groove, and you can use your crescent blade to go and do a dissection, just similar to the way you would do for an SICS. However, the trick is once you reach nearly around half of your area, you would see that it's difficult to now proceed to the other half of the cornea. So in which case what you can do is you can just cut across using your corneal scissors. You can increase the wound size. You can just cut across the wound so that now you have an easy access to reach to the other side of the cornea to complete a dissection 360 degrees. So you don't require any special dissectors. A simple crescent knife by itself can help you to complete a 360 degree dissection of your donor cornea, which you can now use for the DSEK surgery. So the tip is, do not proceed unless your anterior chamber is pressurized, the artificial anterior chamber, because if it's not properly pressurized, you may end up having a anterior perforation or a posterior perforation of a donor tissue. Use a tissue with a good size of the rim. If you think the clarity is not good enough, you can remove the epithelium. And after you have dissected, you can even mark on the stromal site so that you know the orientation after you've inserted the graft inside. Now moving to the site of the incision, you can usually try to use the same incision as you are using for your cataract surgery. If you're a beginner, you can initially use a scleral incision because that's easier, because you can make a little bigger incision around 5 to 6 millimeter in size. And if you are having a patient who has got a filtering bleb, you can use a temporal one. Remember, the internal lip, which is posterior to the graft-host junction, can be used for failed graft. Again, the size of the incision can either be 3 millimeters or 5 millimeters. It's preferred to use a 5 millimeter when you're a beginner so that you compress the tissue lesser and in turn have lesser endothelial cell loss while you're doing the insertion. Initially, people would prefer doing a taco fold, a 60-40 fold. However, it's seen that the endothelial cell loss while doing this fold is much higher compared to now using simpler techniques like your sheet glide or just pushing the tissue inside the anterior chamber by placing it on a cohesive viscoelastic. So a simpler technique like using a 5mm incision, and you can usually just pull it through. You see that the endothelial cell loss is much lower in those cases. So again, for beginners, have an adequate size of your incision. Smaller incisions lead to more compression of the tissue, and if you are having a scleral incision, try to have a good hemostasis before you try to insert the tissue inside the eye, or else if you don't have a hemostasis, the whole anterior chamber will be filled of blood. It will be very difficult for you to manipulate the tissue inside when the blood is there. Again, Descemet stripping is an important thing. When you're trying to strip, just see to it that you have adequately stripped the Descemet membrane. So a reverse Sensky hook is what is preferred. Don't try to go very hard because you don't want to pull on the stromal fibers, because if you're doing that, you'll lead to more scarring of the tissue in the stroma. And if it's a simple case of PBK, you don't even need to strip the Descemet membrane. Only a diseased Descemet membrane, like in case of Fuchs dystrophy, needs to be stripped out. For a PBK, you can just do a non-stripping endothelial keratoplasty, which is just good enough. So if you are not able to visualize your Descemet membrane properly, you can use a forceps, a chandelier illumination, or a trypan blue light. All of these can help you visualize the Descemet membrane easily and help you strip it out of the cornea. Or also you can fill the anterior chamber with air, which gives a good contrast, and then you can do an air descemetorexis. Again, like if the diseased Descemet is not diseased, like it's not a case of Fuchs dystrophy, you can just do a non-Descemet stripping endothelial keratoplasty and they give just equally good results, and there is no increased haste in the interface whether you score or don't score the Descemet membrane. Again, for beginners, they can use Helon in the anterior chamber so that it's easier for them to strip the Descemet membrane, and ensure a complete removal of your Helon after stripping the Descemet membrane. Donor insertion, easiest technique is to use a sheet glide. Place a viscoelastic, cohesive viscoelastic on that, and you can use your bent 26 gauge needle or a Sensky hook to just push your endothelium, the graft, into the anterior chamber. And it's always going to be the correct orientation of your graft because you're placing it properly into the anterior chamber, and there is no question of it opening the reverse side down. And it's one of the easiest techniques which anybody can follow. Any cataract surgeon who's well versed with inserting an IOL can insert Descemet's the DSEK lenticule into the anterior chamber with the right side always down. That's the endothelial side down. And with the glide, you can see that endothelial cell loss is quite minimal, and it gives good results as well. So again, choose one method, master that by keeping on repeatedly doing the same method. Air tamponade. In the initial cases, try to have a complete air tamponade, maintain it for a longer time, and at the end of it, you can just burp a little bit of air to prevent pupillary block, so that you don't have a patient's IOP doesn't increase. Again, it's important that while doing the air injection, you just go below the lenticule, otherwise if you may land up having an air above the lenticule, which may be difficult sometimes to remove, and you also be very gentle, otherwise you may just land up dislocating the lenticule. Even sometimes the lenticule may just come out of the eye. And don't try to overfill the eye, because otherwise sometimes you see subconjunctival air migration also. So have a complete air fill, partial removal of air. At the end of the surgery, you can put the dilating drop to prevent pupillary block in these patients. Thank you very much.